All right, we're delighted to welcome Dr. Alexis Gunderson, one of our Trinity Fellows, to present to us today on the whole issue of cannabis and its role in hospice and palliative medicine.
So like Dr. Mulder said, I'm Lexi. I'm one of the fellows here at Trinity. So I decided to do my presentation on medical marijuana today. I recently took a job out in Salt Lake City, and Utah is a much more conservative state compared to Michigan. So medical marijuana is legal there, but recreational use is still illegal. I did my residency out there, and we often had patients coming in to our clinic asking for information on how to get their medical marijuana card and medical marijuana in general. So I thought since I'm going back there, this will be an interesting thing to learn about. This is just a brief outline of what we're going to cover today. So we'll talk about like different terminology in regards to marijuana, the history and evolution of cannabis over time, some pharmacology, what products are FDA approved, regulations regarding medical cannabis products, some adverse effects, and initiating marijuana. There's a couple different protocols you can use for this and when you can consider using it for patients. So it's the left button. Okay, perfect. So I was really sheltered growing up, and I didn't know all these different cannabis terms. So I thought it would be helpful just to have a basic understanding of different terminology you might use. So cannabis is just a broad term describing products and chemical compounds derived from cannabis sativa, which is the main plant that is grown. Other things you might hear it referred to include marijuana, ganja, pot, dope, Mary Jane. I'm sure there's plenty of other terminology used for this as well. Cannabinoids themselves are the biologically active chemicals naturally occurring in cannabis plants. You might also hear them referred to as phytocannabinoids, and then you can have synthetic cannabinoids as well. Hemp is a type of cannabis plant with very low THC concentrations. It's less than 0.3% THC, and they'll have more predominant CBD concentrations, and hemp is often used in the textile industry. Hashish is an Arabic term used to describe the resin of the cannabis plant in some regions. In other parts of the world, it's just referred to the plant in general. And terpenes are components that produce the plant's smells, taste, and appearance. All right, so going into the history of cannabis, the cannabis sativa plant is one of the world's oldest cultivated plants, and it's indigenous to Central Asia and the Indian subcontinent. The earliest written records of human use date from the 6th century BCE or before Common Era, but there's evidence that its use in Europe and East Asia even earlier than this. This painting here, I don't know if you can see the mouse moving, but it dates from 5000 BCE and was found in a cave in Japan. This is the time when hemp was first cultivated in Japan, and they think this is the oldest known illustration of a cannabis leaf that has been discovered thus far. By about 1000 BCE, cannabis was starting to be used in Hindu tribes in the Indian subcontinent. They made this kind of cocktail called bahang, which is an edible form of cannabis that's ground into a paste with a mortar and pestle. And this image here on the left, or on the right, is Shiva, or also known as the supreme being in the Hindu faith, and he's just prepping himself a potion of the bhajam. All right, more of the history. So when did it start being used for medicinal purposes? The earliest records date from China, and there's some evidence in ancient Egypt too of the use for medical cannabis. In the Ebers Papyrus, which dates from about 1500 BCE, they document the topical application of cannabis used for inflammation. The Ebers Papyrus, also known as the Papyrus Ebers, is just an ancient Egyptian papyrus of herbal knowledge that dates from this time frame or time period, and it's the oldest and most important medical papyri in Egypt. Medical use of cannabis was used during the Roman era. Different philosophers mentioned it, including Pliny the Elder, Dioscorides, and Galen. But Western medicine didn't really adopt the use of cannabis for medical reasons until the 19th century or early 20th century. This is a picture of Queen Victoria and she was known to use cannabis for painful menses. She didn't smoke the plant, but used like a tincture of oil that was derived from the plant itself. She used other things too, like opioids and things throughout her life for various reasons. But despite this really long use of cannabis, it wasn't until 1964 that THC was identified as a psychoactive component in the cannabis plant itself. Oops, oh shoot, I can't go back, can I?
Right click.
Hit the wrong button. Sorry, I hit the wrong button. Just like too bad.
I can't, it doesn't look like it. Here we go.
Oh, perfect. Thanks, Dr. Mulder. So the US itself has its own really complicated history with cannabis. In 1850, cannabis was actually described in the United States Pharmacopoeia. This is an independent, nonprofit, non-governmental pharmacopoeia that sets quality, purity, strength, and identity standards for medicines, food ingredients, and dietary supplements. So it's a little bit different than like the FDA regulations, but the FDA often uses what they publish or making standards for over-the-counter and prescribed medications. So pretty interesting. Around this time, cannabis was actually used as like a patent drug by physicians a lot in the US. In 1937, that's when the passage of the Marijuana Tax Act came through, and this required taxation of the sale of marijuana. And I thought this was also really interesting. The AMA actually opposed this idea because the tax would be imposed on physicians prescribing cannabis, retail pharmacies selling cannabis, and medical cannabis cultivation and manufacturing. So it was around like the 1920s, 1930s when kind of social, politically, the use of cannabis became a lot more controversial in the United States. There's a lot of reasons for that that we won't go into specifically. So by 1942, they removed cannabis from the United States Pharmacopoeia. 1951 saw the passage of the Boggs Act, and this set mandatory sentences for drug convictions. A first offense conviction for cannabis possession carried a minimum sentence of 2 to 10 years and a fine up to $20,000. In 1956, they passed the Narcotic Controlled Act, and this included increased penalties for selling or possessing opiate drugs, cocaine, and marijuana. And there was even the option of the death penalty for selling these drugs if they were sold to juveniles. It also gave the Federal Bureau of Narcotics more powers for enforcement and allowed them to do warrantless searches on people. In 1970, they passed the Controlled Substance Act, and I think this is the one we're all probably a little bit more familiar with. So this included increased penalties for selling or possessing opiates, cocaine, and never mind. This placed all substances, the Controlled Substance Act, that were previously under federal regulation from these other acts, so like the Boggs Act or Narcotic Act, into the scheduled, so 1 through 5 schedules, based on the substance, its medical use, potential for abuse, and safety or dependence liability. Marijuana at this time was listed as a Schedule 1 drug. In 1996, California became the first state to permit legal access to medical cannabis. And since then, as we know, many other states have granted legal access to both medical cannabis and recreational use. In 2018, Michigan became the first state in the Midwest to legalize both medical and adult use marijuana. So this, again, that timeline was just like kind of brief picture of everything I talked about in regards to the different acts and how they fit into the United States. So with the, big changes in how cannabis is used in the United States over time, the cannabis plant itself has changed in that same time frame as well. This study analyzes the time period from 1995 to 2004, And it's looking at the concentration of cannabinoids in illicit products that were seized by the Drug and Enforcement Administration, or the DEA, within that time period. And it particularly looked at the concentration of THC and CBD in these illicit cannabis products. And over time, it showed that, sorry, the dates are a little small on this, but since 1995, the concentration of THC was about 4%, and by 2014, it increased to 12%. During the same time frame, the average CBD content in these illicit cannabis plants has fallen as well. And with that really increase in THC, it's placing patients at higher risk for adverse effects, because THC is the psychoactive component of cannabis plants. Ryan, I thought of you for this, but during the same time period, the authors in the study demonstrated correlating increased use of drug-related ED visits. So as the THC concentration in plants increased over time, more patients were going to the ED for medical side effects related to this. The high THC concentration really increases the risk in adolescents as well. I was reading this little Yale Medical School article that even reported in 2017, this continued to increase in THC concentration is up to like 17% in a lot of plants. So we're still on that upward trajectory. Okay. So that's a little basic history. Now we'll go a little bit more into the pharmacology of cannabis. Naturally occurring cannabinoids are found in the plant itself, and there have been reported over 500 different chemical components of the plants, including phytocannabinoids, terpenoids, and flavonoids. THC and CBD are the two most well-known and the ones that we think about in the medical world. Few of the structures of these naturally occurring cannabinoids or phytocannabinoids are fully understood pharmacologically. And as we know, plants can be grown to have different concentrations of THC and CBD. Synthetic cannabinoids have a cannabinoid-like action, but not necessarily the same phytocannabinoid chemical structure. They have many of the same physiologic effects similar to cannabis, so the plant itself, but the effects of the illicit synthetic cannabinoids are often more intense or longer lasting, and that's probably due to the higher THC concentrations that are occurring over time. So differentiating between THC and CBD, THC is the main intoxicating or psychoactive component of cannabis. It's also thought to have analgesic and antiemetic properties, while CBD is traditionally considered non-intoxicating and non-psychoactive, but may have some anxiolytic properties. The structural difference between THC and CBD is actually pretty small. It's just this hydroxyl group here on the CBD, where there's like a cyclic ring on THC here. Despite this slight difference, they have profoundly different pharmacologic properties. So diving a bit more into both, like I said, THC is the psychoactive cannabinoid. Its pharmacokinetics and pharmacodynamics really vary by route of exposure, and we'll talk a little bit more about that later. It's lipid soluble, but transported throughout the body bound to plasma proteins. It's metabolized in the hepatic cytochrome system using cytochrome 2C9 and CYP3A4. Its primary active metabolite is 11-hydroxy-THC, and this active metabolite is thought to be about 4 times more psychoactive than THC itself. Its inactive metabolite is THC carboxylic acid. It's eliminated primarily in the feces, about 65%, and urine 20%, and has a really long elimination half-life of anywhere from 25 to 36 hours. It's felt that this slower elimination half-life is due to slow release from lipid storage compartments and having to go through the enterohepatic circulation. Like I said, CBD is a non-psychoactive cannabinoid. It's felt to have anxiolytic effects. among many others such as antioxidant effects. It's felt to have a safer profile and have greater therapeutic potential compared to THC. Like THC, it's also lipophilic and can be transported by plasma proteins. And although there's been a lot of research into CBD recently, and we know it's active in many different cellular and physiologic processes, its mechanisms of action kind of remain a mystery at this point. So how do these two components play a role in our bodies? So the endocannabinoid system, or the ECS, is a vast network of chemical signals and cellular receptors that are densely packed throughout our brains and bodies, and they work to control the levels and activities of most other neurotransmitters. It is a more newly discovered system in our body, and it's under a lot of preliminary research still. The system works to kind of keep homeostasis and regulate many key body functions, including learning, memory, emotional processing, inflammatory and immune responses, sleep, temperature control, pain, and eating. Our bodies itself produce endocannabinoids, which are lipid-based neurotransmitters. They're really structurally similar to the molecules in the cannabis plant, or those phytocannabinoids. These neurotransmitters are really rapidly synthesized and metabolized, so they have a short duration of action, and they essentially act on demand to maintain homeostasis and keeping these body functions going. So there are two known cannabinoid receptors. They were both discovered in the 1990s. So if you remember back, THC, the psychoactive component, was identified in about 1964. So it was about like 30 years later or so that it took for them to find these two receptors it acts on. These receptors are G protein coupled receptors, and they inhibit adenylene cyclase and stimulate potassium conductance. CB1 receptor, which is in kind of the screen color here, is mostly found in the CNS. It acts presynaptically and inhibits the release of lots of different neurotransmitters, including acetylcholine, L-glutamate, GABA, norepinephrine, dopamine, 5-hydroxytryptan. These receptors are in there's a high concentration of these receptors in areas that regulate things like appetite, memory, fear, extinction, motor responses, and posture. CB2, which is the blue signal, or the blue receptor on this picture, is found more peripherally in the immune system, the peripheral nerve terminals and vas deferens, and is thought to play more of the role in regulating immune responses and inflammatory responses. The psychoactive effects of THC predominantly occurred to its activation of these CB1 receptors in the CNS. So you can see that kind of all throughout the brain and spinal cord here, with some in the periphery. And CBD has a lower affinity for these receptors compared to THC. So now we're going to talk a little bit about the difference between the FDA-approved products versus medical marijuana itself. There are 4 FDA-approved products: Epidiolex, Marinol, Syndro, Sexamit, and we'll go through all of those next. And then differentiating those products from medical marijuana. So medical marijuana itself is using the cannabis plant or the cannabinoids extracted from it as medical therapy to treat disease or alleviate symptoms. Medical marijuana is prescribed by physicians as well. All right, so first is Epidiolex, or cannabidiol. It's the only FDA-approved plant-derived cannabinoid for medical use, and it's solely approved for the use of management of several specific childhood seizure disorders. So not all childhood seizure disorders can this be used for. I didn't go into the specifics for this presentation, but it's administered as an oral solution that is swallowed. Marinol, which is one I think we're all a little bit more familiar with, or dronabinol, is a synthetic cannabinoid really similar to THC. It's FDA approved for anorexia associated with AIDS and chemotherapy-induced nausea and vomiting, and it comes in capsule form. Syndrose is essentially Marinol, but in oral solution. So again, it's the same active ingredients like a synthetic THC component, and it has the same FDA approved uses. So the anorexia and AIDS and chemotherapy induced nausea and vomiting. But helpful to know that there's the oral solution form if patients are having trouble with capsules and you want to use this. Lastly, there is Sesamit or Nabinol. It's again a synthetic cannabinoid similar to THC. It comes as a capsule, but its only FDA approved use is for chemotherapy induced nausea and vomiting. So different from the Syndrose and Marinol that it doesn't have the anorexia and AIDS approval. Okay. So those were the 4 FDA products. Going back to medical marijuana, that's using plant products itself for a treatment of symptoms or disease. States where medical cannabis is legal, they have different regulations and testing to confirm if there's any contaminants in the products and confirm cannabinoid dosing and labeling. What makes it complicated with this, since it's not FDA regulated, marijuana is still not federally legal, all these regulations differ from state to state. So it can be a little confusing if you're jumping around or your patients are moving between different states. The ratio of the THC and CBD in these products can vary, and the National Institute of Health has determined the standard unit for these products should be 5 milligrams of THC. This has been a really hard part of research into cannabis for use because the concentrations between the THC and CBD can be very, depending on the product, how it's grown, and how people are using it. So they're really trying to get research to use the standard unit to help better things in the future. If patients are interested in using marijuana products for symptom management, regulated cannabis is a lot safer and more predictable compared to getting unregulated or street cannabis. Street products can be contaminated with pesticides, heavy metals, molds, microbes, mycotoxins. So it puts your patients at a lot higher risk of having adverse effects. And they've also shown that street products can often be laced with nicotine to increase the weight so that it sells for like a higher price with having less of the marijuana in it itself. And a lot of people don't even know the products they're using are contaminated with nicotine. So can complicate things as well. Okay. So in Michigan, both medical and recreational use is legal, and there are 2 different types of dispensaries. Both are regulated by the Cannabis Regulatory Agency here in Michigan. So if you have patients that want to use marijuana products, it's better for them to go to these type of dispensaries rather than using street because of the risk of contaminants and like the nicotine lacing that you have. So medical dispensaries, to go here, you must have a valid marijuana card in Michigan, and that's given to you by your doctor. These patients have to have qualifying medical diagnoses to be eligible for a medical card, and these include things like cancer, Alzheimer's, hepatitis C, AIDS, and several others in Michigan itself. And compared to the recreational dispensaries, medical dispensaries can have higher potency products available, and patients can purchase up to 2.5 ounces of product per day. For recreational dispensaries, you just need to be 21 years old and have a valid photo ID to get in. So it's much more accessible to the general public, and consumers can purchase 2.5 ounces per transaction, but the max concentrate of THC they can get is 15 milligrams.
So what is the max concentration on the medical side? Do you know what that is?
Yeah, we're gonna talk a little bit about that later on with like initiating the protocol.
And if you want to talk this later, that's fine too, because when it became available recreationally, the question that I had is, why would people go through the hassle of getting a card when they can get a recreation?
Yeah. Yeah, it's like 40 milligrams per day of THC is kind of the recommended max dose range. And if you're using higher concentrations of that, they really want you to follow closer with like a well-educated provider for it for the medical part of things. So I guess depending on what's going on, like you said, here in Michigan, it probably doesn't matter as much because you have access to both depending on your age. I guess for pediatric patients, they would still need the medical marijuana card.
Yep. Okay,
but-
well, I just was curious. Thanks.
Yeah. Okay. So again, I'm very naive about, and when patients come in, they're talking about all these ways they use marijuana products. I don't know what they all meant. So I figured it'd be helpful just to go through how you can consume these products. A very common one is inhalation. So this can either be a combusted cannabis flower in a cigarette or pipe, or you can vape the dried cannabis flower or vape an oil-based concentrate in like the battery operated vape device. If not using regulated products, remember that they can be laced with nicotine. So you just want patients to be aware of that. Okay, so a little bit difference between combusting the flower and then like vaping the oil or flower. For the combusted flower, the bioavailability is anywhere from 10 to 35%. Has a really quick onset of action of 3 to 10 minutes and a shorter duration of action, about 2 hours max. The bioavailability for the vape products really varies from 2 to 56%. Its peak onset is about 9 minutes and again has a pretty short duration of action, about 2 hours max. It's felt that the bioavailability between these products is so variable because of differences in the number of breaths patients are taking, the duration of the puff, how long they're holding their breath, the inhalation volume of each breath. So kind of hard to know exactly how much product that they're getting with this method. Some advantages for patients are that it's a really quick onset of action and it's pretty easy to titrate the dose that you're getting, especially for the regulated products, because they usually increase by like 2.5 to 5 milligrams in the products. But disadvantages of this method of use include intoxication. You can get chronic bronchitis. There's the potential for contamination. Like I said, if you're using the unregulated products, not only with nicotine, but some of those like molds and pesticides as well. And then if you're vaping, there's always the risk of vaping induced lung injury. And that was pretty prevalent in the last decade, especially in kids. Another really common one we think of are ingested products. So these can be capsules, chewable candies, like gummies. There's also suckers, chocolates, things like that. And then you can get baked goods. With the capsules and candies, you usually have cannabinoids extracted from the plant. But the baked goods can have the whole flower in them. The bioavailability is anywhere from 4 to 25%. It's a little slower peak onset of action, like 1 to 5 hours, but has a really long duration of action of up to 25 hours. The bioavailability variability is thought to be due to some drug degradation in the stomach. There's variable absorption, and it has to go through first pass metabolism. So some advantages for patients that want to use this, it has a really long duration of action. So if you have like a chronic persistent type of pain, it could be a good choice. And it doesn't have any of those adverse effects associated with inhalation. But some disadvantages, there's the risk of dose stacking with the slower onset of action. So if people are eating these gummies and they're expecting an immediate response, they might consume more than they know they are, and then really feel the effects when they start to kick in about an hour or so later. They're more difficult to titrate, and there's a lot of variability in absorption depending on individual patient factors such as their weight, how much fat content is in their meals they're consuming around the time they're eating the plant, and things like that. You can also get sublingual or products that you kind of spray onto the oral mucosa. So the oral solutions are just put under the tongue and absorbed, or there's like different sprays you can use for the mouth. These solutions contain extracted cannabinoids from the plant itself. It has a really, really high bioavailability, like 87 to 90%. Fairly quick onset of action of 10 minutes and a pretty good duration of effect, about 10 hours max. Pros for this form of product include a fast onset of action. It avoids the adverse effects with smoking or vaping products, and it can be used in patients with swallowing difficulties. These products do tend to taste pretty bad, and there's potential for user error if they're swallowing the products instead of letting it absorb completely under the tongue around the mucosal surface. You can get oil-based rectal suppositories, and these also contain extracted cannabinoids. The bioavailability, again, is really variable, 14 to 67%, a bit slower onset of action of 1 to 2 hours, and like a moderate duration of effect of 8 hours max. Some pros for this is that it avoids first pass metabolism, and again, you don't have any of those smoking and vaping risks, but it's a really inconvenient dose method, and there's a really, for like general marijuana doesn't have the best evidence for it, but there's really, really little supporting data for the rectal use. Topicals. So as we know, there's a bunch of different products in regards to this: lotions, creams, ointments, balms, oils, and even a transdermal patch. I wasn't aware of that product before. And these all contain extracted cannabinoids. So the bioavailability of topical products really varies depending on the formulation, heat application, and amount of fat and tissue where it's applied. I didn't even see like a guesstimate on percentages of bioavailability when I was reading on this. It has a slower onset of action of 2 hours, but a really long duration of effect of up to 48 hours. There's some advantages with avoiding, again, that inhalation risk factor and the longer duration of action, but it's really hard to know how to titrate these products and what type of bioavailability patients are being exposed to. And lastly, there are dabs and waxes. So these are cannabinoid concentrates with really, really high THC concentrations, and they're applied to a hot platform and inhaled. The concentration in these type of products is often over 60%, and this translates about to 5 milligrams of THC in a single inhalation. And as you can see, there's tons of different forms of dabs and waxes themselves. I don't know the specific difference between all of these, but there's a lot. The bioavailability for dabs and waxes is unknown, but you're going to get that peak onset immediately after you inhale, and it has a shorter duration of effect, 2 to 3 hours. Some advantages are it's a really quick onset of action, but cons include the potential for lung injury, just like with inhalation or vaping. There's a higher risk for exposure to solvents. A lot of these products are unregulated, and the risk of adverse effects like psychosis is extremely high just because of the really high THC concentrations in them. So this table, sorry, it's a little small, but it just compares all the different routes that you can consume cannabis products in, their bioavailability, their peak or onset of action, how long they're gonna last, and pros and cons for each. So we mentioned some of the adverse effects and how they can vary depending on what type of product people are using, but just in general, short-term use can have problems with impaired short-term memory, impaired motor coordination, altered judgment, paranoia, and psychosis. But long-term use can come with risk for addiction, altered brain development, cognitive impairment, poor educational outcomes if teens or adolescents are starting this, diminished life satisfaction overall, chronic bronchitis with the inhaled forms of products, and increased risks of chronic psychosis-related health disorders, especially if you're using those really high THC concentration products like the dabs and waxes. Most of this information regarding adverse effects comes from studying recreational users, so there's not a ton of great data in like actually using it for medical purposes, either those FDA approved ones or just medical marijuana in general.
You've mentioned regulated and those that are not. When you talk about regulated, are the products that are available in medical marijuana dispensaries, is there some regulation of those?
Yeah. Okay. Yep. So that's like it's like the Cannabis Regulatory Agency for Michigan. is the one that regulates both the medical dispensaries and the recreational dispensaries. And they
So
have,
someone's measuring it for purity and.
yeah, and checking for the contaminants, and they have to be pretty specific on the labeled doses
Yeah.
for the CBD and the THC concentration.
I guess that's comforting to know.
Yeah, so a lot better for people to go there if they want to use
Than on the
rather
street,
than on the
yeah.
street because of all the potential not really knowing what they're getting. So we've talked a lot about now, like the history of cannabis, how it's evolved over time, the different products and the bioavailability and some pharmacokinetics with those. So if you think you want to start medical marijuana in a patient or they're interested in it, how do you do it? Well, it's pretty simple. You choose a product to start with. So whether that's like a smoking product, a gummy, the sublingual or oral sprays, you just pick one formulation, choose a starting dose, and then increase the dose as needed to treatment goal or the kind of max concentrate. So it's like 40 milligrams of THC is really the cutoff there per day total. There are 3 different initiation protocols we'll go through. They're all from the Journal of Cannabis Research, and it was published in 2021, so pretty new. First is the routine protocol, and this is recommended for most patients. So you start with a CBD predominant product, and that dose is going to be 5 milligrams twice daily. You're going to increase the concentration of CBD in the product by 10 milligrams per day every 2 to 3 days. Once you get to 40 milligrams of CBD per day total, if you're not at the treatment goal, then you're going to add THC into the product. And you're going to start that THC dose at 2.5 milligrams per day and increase the THC concentration by 2.5 milligrams every 2 to 7 days until goals are met or you're getting to the max concentration of THC of 40 milligrams per day.
Are you going to talk about indications?
Yeah.
Okay.
Yep. So for the routine use, they picked like a CBD predominant variety to start with because it's more tolerable, has a better safety profile, and doesn't have that euphoria associated with THC. There's a lower risk of adverse effects overall with those CBD predominant products. Next, we'll talk about the conservative protocol. So this is recommended for patients who might be more sensitive to drug effects, like your clinically frail or elderly patients. If they have a lot of complex comorbidities, they're already struggling with polypharmacy or have some mental health disorders. So same as the routine, you're going to start with a CBD predominant product, but the CBD dose can either be 5 milligrams daily or twice a day. You're going to up titrate the CBD concentration by 5 to 10 milligrams per day every 2 to 3 days. And again, if you're not at treatment goal when getting to 40 milligrams of CBD per day, you're going to add THC in. The THC starting dose for this conservative protocol is smaller at 1 milligram per day, and the rate of increasing the THC concentration is slower as well, increasing by just 1 milligram every 7 days until you're getting to treatment goal or you're getting to that max THC of 40 milligrams per day. And lastly, you can have a rapid titration protocol, and you can consider this in patients that are needing more urgent symptom management or those with significant prior use of cannabis products. You're going to start with a balanced THC and CBD product. So for the other two, you're starting with a CBD predominant. So that's one difference. The starting dose is going to be 2.5 to 5 milligrams of both THC and CBD in the product, and you can dose it once or twice daily. And then you're going to titrate up the dose by 2.5 to 5 milligrams of the THC and CBD every 2 to 3 days until you're getting to your treatment goal or getting to those maximum concentrations of 40 milligrams per day. All right, so now when do we think about using marijuana products in patients? Most research into medical cannabis is focused on using it for chronic pain, but pretty much every study is really low to moderate quality and evidence at best for using these products. And this is due to a lot of different reasons, including small sample sizes that they're studying, really short follow-up period, so there's not great like long-term evidence for marijuana products and their use. A lot of the studies are non-blinded or unrandomized, so there's a lot of bias in them. And none of the studies really use a standardized dose or route of administration. So as we know, the bioavailability can really vary between the different types of cannabis products. And if you're not controlling those in studies, you don't really truly understand the effect that different patients are happening. This study in particular looked at different types of both synthetic products and plant-based products for the use in chronic pain. It's just a review of all the studies that were available. It found that synthetic products with the high THC to CBD ratios, like even greater than 98% THC, were associated with some moderate short-term improvements in pain severity. But these really high concentration THC products also are associated with moderate increase in risk of adverse effects, especially sedation and dizziness. These studies showed that the improvement of pain was best seen in like a chronic neuropathic type of pain. They also found that plant extracted cannabinoids, so not the synthetic, like more the medical marijuana, that had the comparable THC to CBD ratios. And if it's given sublingually, you might have some short-term improvements in chronic neuropathic pain, but there's really insufficient evidence regarding other products and the effect on both neuropathic and other types of chronic pain. Other explanations as to why the level of evidence might be so low is just due to limited availability of investigational products, because the legal status varies depending on what state you are in the United States, and it's still legal in a lot of different countries as well. And it's felt that often in these studies, there's an overemphasis on pain scores alone to define efficacy. So definitely more studies are needed on long-term outcomes for these products and the effects of different formulations of these products on pain. Another really common use that we think about is using it for chemotherapy-induced nausea and vomiting. So we know there's the 3 FDA-approved medications for this. Marinol and Syndros are the dronabinol. Marinol is the capsule form. Syndros is that oral liquid form. And then Sesamet or Navinol. They have had several randomized trials comparing these synthetic cannabinoids to placebo, but none again are high quality or clinically controlled studies. These studies that are available appear to have some modest benefit, but again, a really significant side effect profile. There has been less information for the medical marijuana use in regards to managing chemotherapy-induced nausea and vomiting. There was this one study in 1988 that I was reading about. It was a prospective uncontrolled pilot study showing that inhaled cannabis was effective in 78% of patients with uncontrolled chemotherapy-induced nausea and vomiting, but the patient group was so small, it was only 56%. And there were no subsequent clinical reports after this addressing how these inhaled or even ingested products affect chemotherapy-induced nausea and vomiting. So again, some potential benefit, but the quality of evidence is not the best. Other potential uses that are being researched right now that, again, don't have great evidence are severe persistent muscle spasms, PTSD, seizure disorders in children and adults. So if you remember, there's the one FDA product, it's like Epidiolex, I think is the brand name, if I pronounce it right. And that's only approved for specific childhood seizures. So there's no approval for adults or other seizure disorders in children. They're looking into cachexia or wasting and cancer, different sleep disorders. I was reading that I think it was Marinol, sometimes even used like off-label for sleep apnea, and then anxiety, and plenty of others still with the new information that's coming out of studying the endocannabinoid system in our bodies. So how does this affect us in palliative care? This was a more recently published systematic review article looking at using these products in the palliative care setting. It came out in June 2022, so fairly recent. This study looked at 20 randomized control trials and 32 non-randomized trials that were available. And the largest patient group throughout all these different studies was the cancer patient, but some studies also looked at people with dementia, AIDS, and other populations. I think there's one that looked at this rare seizure disorder. There were a lot of challenges when they were doing this review though, because again, there's no standardized patient populations in any of these studies. There's no standardized cannabis-based interventions, so different products are being used with varying dose regimens. The outcome to measure these changes was also really highly variable. There was felt to be a lot of risk of biases in the studies because of them being non-controlled. And a large number of adverse effects was reported, but there was never a consistent way of assessing or reporting these effects for patients. So overall, the publishers of this article felt that the evidence for the outcomes assessed in all the studies was low to very low. So even though we have patients that say they get benefit, we should interpret these results with caution because the true effect of medical cannabis products is likely really different from the estimated effects just based on patient experiences and what people see. And that's just, it's really hard to control these studies with how variable these products can be. Besides this review article, there have been various other review articles in different studies looking into the use of cannabis products in palliative care as well, and they all have had similar conclusions that there's no strong evidence for use of these products in the palliative care setting at this time. So moving forward to inform evidence-based practices, it would be helpful for researchers to consider different aspects of like a high quality trial design, including standardizing participants, standardizing interventions, and making it easier to analyze the adverse effects that are being reported, and having the ability to perform a meta-analysis on their findings. So that's a lot, just some take-home points to remember. There are naturally occurring cannabinoids, and these are the THC and CBD products. THC is the psychoactive cannabinoid and acts primarily on the CB1 and CB2 receptors. CBD has a lower affinity for these receptors. Synthetic cannabinoids have cannabinoid action, but structurally are different from the plant-based cannabinoids. There are the 4 FDA-approved products. Epidiolex, that's the one for pediatric seizures. Marinol, Syndros have the anorexia and AIDS and chemotherapy-induced nausea and vomiting approval, and Sesamit is just for chemotherapy-induced nausea and vomiting. Regulation for medical marijuana products aren't federally followed. They vary from state to state. We talked a little bit how those vary here in Michigan. And in regards to THC and products, that has steadily increased over time, increasing the risk of adverse effects. And you can grow plants to have varying amounts of THC and CBD in them. There are a lot of different protocols that exist for initiating medical marijuana, and we reviewed the conservative, routine, and rapid titrations. And though there are studies showing the benefits to the use of marijuana, none of them are high quality and evidence right now. So definitely more research is needed into the use of these products, not only in the palliative care setting, but just symptom management in general. And that's all I have for you. These are my references. Thanks for listening.
Yeah, let's stop the screen share here. Open it up for comments, questions, curiosities from the group.
I was wondering, did you come across anything like since it's become legal to buy marijuana in Michigan, like, is there any statistics on how many people buy
I did not
from dispensaries versus like
think
on the street? Okay, I just
for
was curious, like if there's been a shift.
sorry.
No, that
One of the questions I had is the medical cards that we could potentially have patients that are reaching out and asking us to fill out for their just general comfort. Like, you know, we've had a couple of people that have asked about it. Generally, the answer that's given is, well, find a dispensary that you think does not feel too shady and go in there and talk to them and see what they have to offer. But is that something that we should be aware of? Is the process for filling out the card, and then what are the implications of what that means for our patients.
Yeah, I didn't look specifically into like Michigan and how to obtain the card since I'm going to Utah. I was more interested in that, so sorry, but I think, you know, depending on the patient situation, there's just some differences between the dispensaries. So if you have someone under 21, they would need that medical marijuana card to fill out, or if you're looking to get the higher concentration of products per like use, I guess, the medical dispensaries are allowed to have the higher potency products compared to the recreational dispensaries. So some minor variabilities, but probably the regular dispensaries.
Yeah, getting the card is not that complex.
Yeah.
You know, you can go online and print out that's what I tell patients to do. And by the way, if you do that, the state of Michigan has chosen to spell marijuana with the H,
Yes,
not the J,
Oh.
but with the H.
that was like the Federal Marijuana Tax Act too. It was like the H.
Yes, and so but you can print that out and it lists the various disorders that are slam dunks, including, interestingly, a nail disorder, which is on that list. So it's an odd list of things. And I think in the most of when I filled out those forms in the past, I just have to write in an other one there. So they take that and they send that in with their check. I think it was $100. That may be less now. I don't know. I haven't done it in quite a while. And that there was a reduced rate or Medicaid paid for some of that if they qualified. I don't remember the exact details. One of the things that a couple of just comments and reactions, the four legal,
FDA.
FDA approved products. I really had never had outstanding results with those. And the rationale that I had, just simplistic and non-scientific. And you sort of alluded to the fact that there's 500 different, active ingredients in the plant, and we're extracting one and expecting that to work as well as the plant does. And I think that it's like having an A-list quarterback in the backfield, but you give him no offensive line. He's not going to be that effective, no matter how good he is, without the rest of the team there. So that's sort of how I justified why that didn't work. And in the early days where I found the Marinol to work, of course, that was approved before it was legal here in the state of Michigan. And the folks that it seemed to work on were young adults who were very excited to be getting legal marijuana. And so I really think there's a high psychological component to its effectiveness in that particular population. The other question that I had, of course, even before it was legal and after legalization, you saw drugstores and pharmacies just deluged with CBD products without really recognizing or identifying clearly that these are not marijuana products. Because my understanding is it's all hemp-based product, and they're not marijuana-based products. And so people would be, paying for all these different CBD products, thinking they're getting some aspect of marijuana, which they are not. So I don't know what anyway.
Yeah, it's like super low. It's like less than 0.3% in those hemp-based products.
Yeah.
Of THC.
Of THC, right?
John, do you know expense-wise of some of the commercially built products like Marinol as compared to, I don't know what the cost is of these dispensaries and stuff that you would get there, but.
So I don't. I know Marinol is fairly expensive and it's hard to get insurance to pay for it without prior authorization. The going into a dispensary, in many circumstances, I found people coming out paying about $40. There's something magic about $40. There's a lot of vitamin mineral supplements that you can get, some that are network marketed, some that you can just but all of these things tend to run around $1 a day, a little bit more than that, 40, 30, 40, $50 a month. And that seems to be a target that marketing has showed is tolerable to a lot of folks in terms of paying for a single trip or a single bottle or whatever. So I don't know if you research
like
numbers at all.
here in Grand Rapids area, like Marinol's at least $112 is the cheapest for a month's supply.
Yeah.
So pretty expensive and can get up to like $100.
And I see a hand up. Do I see a hand up over Corwell? But, is that something else? Oh, no, that was, never mind. That was a cursor. It was a cursor that was right over over your square there. But, Karen has a question here in the chat box. I'm curious how researchers measured the patient's reports of benefits taking the marijuana. I wonder how many patients would say it was very effective, even if other research measures in the study would find a limited effectiveness.
Yeah, I think that was one of the problems, the way they reported this, the stuff variable between the studies and not really consistent, and they often just use like the pain scores, and as we know, pain scores aren't always the best option for determining efficacy. They can vary from patient to patient.
Yeah, the other observation is that relative to Karen's concern about bias in reporting, a lot of the people that participate in the study really want it to work.
Mhm.
And so if you've got a non-blinded study, open label study, essentially,
Yeah.
then is that going to bias their reporting?
Yeah, and that's pretty much every study is felt to be.
Well, it'll be interesting to see if the reclassification now will in fact open up the door to more research opportunities and proving that what it does and what it doesn't do.
Yeah, I think there's a lot of good potential, but it has to be a lot more standardized to know the potential effects.
Okay, great. Other questions or comments for Lexi?
Yeah, this is Rob. Great talk. It'd be interesting with the reclassification. I get asked occasionally in the nursing home setting as a trial for folks with dementia. It's almost like a Pandora's box. I wonder how much more interest there will be when the reclassification happens. Right now, I have, my standard sentence, like it's a federal law against it, so there's no way I can prescribe it at this point. But if that sounds like it's going to materialize, that's going to change. So.
Yeah, I'm often curious when they talk about our prescribing. I saw an article last night about the psilocybin, and they're talking about prescribing that. Well, technically, I guess that's a broad generic term. That if we just recommend something or advise someone, is that really prescribing? I can't write a prescription for that. Even if at this point, even if they reclassify schedule, I can't write a prescription for that because there's no pharmacy that's going to fill that, right? And so I don't understand the terminology there.
Yeah, that's a good point. It would be up to the families to bring it in, I guess, and get. I have to prove everything whenever anything's taken in the nursing home setting per se.
Right. Yeah, you've got a little bit higher bar and more restrictions than those of us that are just in the community.
Can I?
Of course.
Yeah, first of all, great topic. It's something I think about all the time. Without seeming like a prude, I feel like society is it's just a big push. I always laugh when I cross the Indiana state line, and I'm always kind of like poking that there's a million billboards now. Buy pot, buy pot. And now in Indiana, you still can't buy it. It's coming. But they're advertising to cross the state line, even though how do you get it back over it? So here's a couple of things I was thinking of. First of all, I don't know if you were able to get an article that might have kind of pinpointed to this. When I was working out in California, they were already, this was 10 plus years, and some of the doctors were already saying with the new kind of hybrid strains that they have, that the concentration is actually strong enough to now go from a psychological addiction to more of a physical addiction, which is another, for me, is a concern. The second thing is we're just kind of promoting this stuff, and we're not looking at long-term effects like you're saying. We really don't. You'd mentioned chronic bronchitis. I'd love to know if any of our oncology colleagues that are listening know about the effect or the possible rate increase of like lung cancer. Because what's going to happen is, okay, we had and if you look at it in a monetary sense, all of these lawsuits for not knowing I was smoking cigarettes, right? When they were sitting there hacking all these years, we got lawsuit after lawsuit after lawsuit against all of these big tobacco companies. But yet, do you see any statements on none, and you know what's gonna happen when that cancer rate goes up.
Yeah.
Somebody's gonna get sued and we're paying for it. And that really, if you wanna go and smoke, hey, I used to tell people when I was a kid, smoke all you want, but don't smoke on my account, right? I don't think society needs to buy that. They need to be putting on restrictions and stating, yes, you might benefit, but yes, there's a cancer risk or there's
Yeah.
you know, and second of all, there is a potential addiction risk.
I think the problem, like you're saying, is like all the studies are so short term and a lot of them are like in the recreational users
Yeah.
too, so it's like.
Anyway,
Better
So
information.
without looking like the prude, I think about this because I think that like with any medicine or drug, we have to think about not only benefit, but side effects, you know, and potential risk in the future. And I just don't see any of that right now. It just buy it and everything's kosher.
Yeah, I agree.
Does anybody know anything on the oncology side? I'm just curious. Or if I'm just making this up in my mind, but I can't imagine that smoking unfiltered marijuana that's causing bronchitis cannot absolutely induce a potential cancer. I don't know. Head, neck, throat, lung, whatever. And again, without these so-called warnings, I'm gonna tell you in 20 years, watch. You should have told me, I didn't know. Okay. You know, you're hacking and coughing, I get it.
So I just quickly, I don't see any oncologists left on the call, but despite all we know about the dangers of marijuana smoke, most of the studies have not found a strong link to cancer. Well, it says most, not found a strong link to cancer. This is more likely due to the small size of the studies and the difficulties mentioned when studying marijuana use. So I don't know that we know that yet. Well, thank you, Lexi. Great talk.